Hi.
Oh,
I am with Dr. Barry Morgenstern, breast and body imager here at Lenox Hill Radiology in, how do you say the name of this center?
Lenox Hill Radiology?
Pachuga?
Patchogue.
Patchogue. Yes, in Patchogue. And you also read for Pure Mammography, right?
Yes, yes. Pure Mammography is a center that we started at my practice at Medical Arts Radiology before it became part of Lenox Hill Radiology. And the concept was to enhance the utilization of screening mammography by women across America, because fact is that many women find it inconvenient to get their screening mammogram, having to initially go to the doctor's office to get a prescription for the mammogram,
Yeah.
then go make an appointment for the mammogram. So it turns out in New York State, one doesn't need a prescription to get a screening mammogram. So the concept was really about screening.
Yeah.
And by placing strategically a mammography center in a shopping mall, we thought we would be able to enhance the ability of women to get their mammogram annually.
Yeah.
And especially many of the women that we see at Pure have
Right.
never had a mammogram before. So lots of baseline
That's
mammograms
crazy.
well beyond
Yeah.
the age of 40.
That's amazing. And so what shopping mall is it? There's more than one, right?
Well, we have two sites now.
Okay.
The first one was in the Smith Haven Mall,
Okay.
which is in eastern Suffolk, and then we have one now in Nassau County at the Roosevelt Field Mall.
That's amazing.
Yeah, and they've done pretty well. I mean, the
Yeah.
Roosevelt Field Mall is a newer site,
Mm-hmm.
so that one's just getting up and running.
Right.
But, the
Right.
other site's done quite well.
Yeah. It's such a great concept because women can just be walking by and it sort of like puts a little thought in their head, right?
Yeah, the average cancer detection rate out of 1,000 women screened is about 4 cancers per 1,000. We've actually found that number is higher in the women that we've been screening at the mall centers, because many of these women, as I said earlier,
Yeah.
have never had a screening mammogram. So the incidence of breast cancer might be a little bit higher than the interval cancers that we see in women who go annually for their
Right.
exam.
Right. That's a great service. And hopefully, more women take advantage of that. Yeah. So let's talk a little bit about you. So you do breast imaging, and what other kinds of imaging do you do?
Well, I'm sort of like the complete radiologist. So not too many radiologists do diverse aspects of radiology as I. These days, most radiologists are super specialized.
Yeah.
But, I've been doing radiology for a long time, for 40 years.
Okay.
So I began my career actually, I trained at NYU for radiology and
Okay.
at Columbia Presbyterian for interventional radiology. So I started out my career as an interventional radiologist.
Okay.
And I came out to Long Island and worked at two hospitals, Huntington Hospital and Southside Hospital. And at the time, interventional radiology was really an evolving specialty, and it's a very exciting specialty.
Yeah.
Basically, using minimally invasive tools like catheters, guide wires, stents to treat using imaging guidance. And many of the procedures we performed at these hospitals were actually first. First thrombolytic therapy for treating clotted arteries, first vena cava filter placement for trapping blood clots, first biliary drainage, draining kidneys with nephrostomy tubes.
Wow. And a lot of those.
First stents
Yeah.
in the arterial system. Actually, radiologists developed stents before cardiologists started putting them in coronary arteries, because the landing zone of the peripheral arteries are larger structures. So technically, it was easier to develop stents for peripheral arterial disease.
Right.
Eventually, the technology became sophisticated enough that we could insert stents into small coronary arteries as small as 3-millimeter arteries.
And a lot of those interventional radiology procedures, they can even replace what used to be like open surgeries, right?
Exactly. I mean,
Yeah.
that was really the whole concept of interventional radiology, is to use minimally invasive techniques.
Yeah.
And So, as our practice evolved into just a purely outpatient practice, I found that it was a natural transition to do a lot of breast imaging, because I was used to doing a lot of procedures.
Yeah.
And as a radiologist involved in interventional radiology, it's more patient interactive. And of all the subspecialties in radiology outside of interventional, breast imaging is actually very much a hands-on patient interactive
Yeah.
subspecialty.
Right.
So I've been doing breast imaging for a long time. I've seen tremendous advances in breast imaging.
Yeah.
I was initially a radiologist in the Air Force, was my first place that I
Oh,
worked.
wow.
It was at Wright-Patterson Air Force Base in Dayton, Ohio. And we were doing zero mammography at the time. We then saw the evolution into film screen mammography, and then eventually 3D mammography with tomosynthesis, digital mammography, and it's been a tremendous time to be involved in
Yeah.
radiology,
And what do
seeing
you
all the
think? Yeah, the
technological advances.
latest advance with AI incorporated.
So, AI is still in its infancy, but it's rapidly becoming a very important tool in radiology. And obviously, breast imaging
Yeah.
is one of the most important areas that we've found a role for AI. Actually, radiologists have been doing AI, if you will, for many
Right.
years. We used to call it CAD. We
Right.
called it computer-assisted diagnosis. So for many years, radiologists would see these little circles appear on the mammograms. It was the computer saying they thought there was a suspected abnormality. But it actually fell out of favor because so many false positives, the radiologists eventually would just ignore the CAD marks because
Oh,
it was just it was not sensitive enough, not
okay.
specific enough.
Okay.
But now, with AI and specifically with the product that DeepHealth
The EBCD.
has developed, it's really become really a very sophisticated tool
Yeah.
now.
Let me ask you, because it's funny, I talk about EBCD a lot, like out at our centers on the West Coast, and I people always ask me, like, what's the difference between CAD and EBCD?
So, as I said, CAD was so super sensitive that radiologists would come to ignore the marks because it just was circling normal breast tissue
Okay.
or benign calcifications. So with the AI
Mhm.
that DeepHealth developed, we not only get circles, but we
Yeah.
get specific levels of concern. So it's color coded actually, green,
Oh,
yellow, orange, and red.
okay.
So if there's a circle and it's highlighted as red, that's a highly suspicious finding. So the radiologist can really, focus on what very suspicious findings are as recognized by AI and sort of gloss over, things that are ultimately not proving to be of any importance.
Right.
Yeah, so the radiologist is presented with an overall assessment by AI, and then specific images
Mhm.
and specific lesions have an AI indication as well.
Right. And are you seeing that you are finding more breast cancers earlier?
Well, the statistics show that we are
Yeah.
seeing an improvement in our cancer detection rate through
Mhm.
AI. The other thing about AI is that radiologists can get fatigued, but AI doesn't get any fatigue.
Right.
We get distracted oftentimes. A patient needs help with an injection, or there's a doctor on the phone, and ideally, radiologists like to read screening mammograms in an uninterrupted environment, but that's not always practical. So it's not uncommon that you get a little distraction, and then suddenly the AI picked up some calcifications you didn't notice when you were looking at the exam. So yeah, I mean it has a lot of value. It's also been shown to enhance the radiologist's productivity, their efficiency in reading it. In Europe, oftentimes, in many countries in Europe, mammograms are double read by two radiologists.
Mhm.
And we obviously don't have that luxury here in the United States, but this is sort of like a second read, if you will.
Yeah.
And in many ways, it's actually, and in some studies, it's been proven to be a better second read than having a second radiologist
Right, right,
read the
right.
mammogram.
Yeah, that's fabulous. So I wanted to ask you, I know you do thyroid,
Hmm.
right? So I'm curious about that. It's something we haven't talked about on this podcast before. So I did want to ask you like a few questions about that. I think that's
Sure.
sort of interesting. Because you hear about thyroid cancer or so let me just ask you this. What is the thyroid exactly and where is it?
Well, the thyroid straddles your trachea.
Mhm.
It has two lobes, a right and a left lobe, and then
Okay.
a little bit of tissue that connects the two lobes called the isthmus.
Okay. I just know you see like a butterfly. People
It's an endocrine structure that
okay.
has impact upon the body's metabolism.
Right.
And, we monitor thyroid function by T3, T4, and thyroid TSH, thyroid stimulating hormone. Um, so those are the functions of the thyroid glands.
Okay.
And The most common disease we see in the thyroid gland is just benign enlargement of the gland called a goiter. And most commonly, there are multiple nodules in a
Mm-hmm.
goiter, and we call that a multinodular goiter. So, what about thyroid cancer? So, the problem is that thyroid nodules are so common. If I went down and I grabbed 10 people in the street and scanned
Yeah.
their thyroid, half of them would have thyroid nodules. So, some people say that there's an epidemic of thyroid cancer, but
Yeah.
it's really not an epidemic of thyroid cancer. It's an epidemic of identifying so many thyroid nodules as incidental findings, and then going on to do biopsies of nodules that are probably innocent and would not
Really.
affect someone's life. So, radiologists have tried to figure out, like, how can we identify the truly suspicious nodules
Mm-hmm.
and minimize excess
Yeah.
thyroid needle biopsies. So the American College of Radiology in recent years came up with a TIRADS scoring system
Okay.
to identify which nodules we can observe, which nodules we could ignore, and which nodules need to be
Right.
biopsied.
Sort of like prostate cancer.
Right,
Mm-hmm.
right. And in more recently, AI is coming into play, and actually, we're in a project right now with this
Oh,
company called Kios, looking at AI and can it improve even further
okay.
upon analysis of thyroid nodules than just radiologists using this TIRAD
Why
system.
are nodules so common?
Well, we don't really know why they're so common, but they are very common. Most commonly multiple. Years ago we used to say if there's a solitary thyroid nodule, that's more suspicious than someone that has multiple
Oh,
nodules. But that's actually been proven to be false.
right.
The fact is that it's the features of the thyroid nodule that are most curious, that are of most importance. So you can have multiple benign-looking nodules, but
Mm-hmm.
if one of them has suspicious features, it doesn't matter that it's a multinodular gland.
Right. Right.
You have to treat each nodule individually like that. The thyroid biopsy itself is a pretty innocent procedure. It's used a very skinny needle. In my hands, it's really a minimal discomfort to the
Yeah.
patient. We do it under local anesthesia, and patients get results promptly. In the old days, if because oftentimes pathologists are not sure, okay? So we would about 20% of the time, we would get an indeterminate thyroid
Oh.
biopsy result. So now what we always gather a second sample
Mm-hmm.
for genetic testing if necessary.
Okay.
So if we get an indeterminate cytology result on a thyroid FNA biopsy, those samples go ahead. The patient doesn't have to come back for another biopsy. We have that genetic test sample, and they'll look for mutations in the thyroid cells. So if there's no genetic mutations in the cells,
Mm-hmm.
patient and the doctor can be confident that that's a benign nodule. But if we identify mutations that are associated with thyroid cancer, that's a very high likelihood that that's a malignant nodule. So it guides treatment. So many patients in the past with an indeterminate result would have unnecessary thyroid surgery. If its genetic test is negative,
Oh.
you wouldn't have to have that.
Oh. Okay. I have two questions.
Sure.
Is thyroid cancer, is it a genetic cancer?
There can be familial
Mm-hmm.
tendencies with thyroid disease in general and with thyroid cancer, but for the most part, it's not a strong uh, risk factor having a family history of
Right.
thyroid cancer.
And I also read that it's more common in women.
It is more common in women. And, the most common thyroid cancer is papillary thyroid cancer,
Mm-hmm.
and these are considered fairly indolent cancers. Um, Not to say that they can't potentially spread to lymph nodes, but for the most part, a very, very small papillary thyroid cancer probably is going to have little to no impact on a patient's life. For
Yeah.
that reason, radiologists are discouraged from biopsying these really tiny papillary cancers. So if
Oh.
it's less than 1 centimeter, endocrine doctors and ENT doctors suggest don't biopsy that because it's not going to have an impact, and just follow it.
Just follow.
But in very young patients, we may be
Mm-hmm.
more aggressive in biopsy subsonic
Right.
with thyroid
Right.
nodules that
So
are
what
suspicious.
what kind of symptoms would somebody want to have checked out?
Well, the most common symptom that someone would
Yeah.
present with thyroid disease is mass-related symptoms. So if it's a bulky,
Mm-hmm.
enlarged thyroid nodule or thyroid gland, They may have dysphagia, difficulty swallowing.
Okay.
They may have difficulty breathing if it's pushing on the airway or trachea.
Yeah.
But most nodules are either picked up as on physical exam by a doctor as a little palpable lump, or
Mm-hmm.
the patient may notice that, or it may
Yeah.
be totally incidental. As I said, thyroid nodules are very commonly seen on imaging studies.
Yeah.
We see them on CAT scans all the time.
Really?
American College of Radiology actually discourages radiologists from overdiagnosing these, to
That's interesting.
minimize the prominence in a report. Yeah.
Yeah, because I was reading that it's the incidence rates of thyroid cancer have been increasing.
Again, I think it's increase in diagnosis, not necessarily an increase in the
The actual
prevalence
rate.
of the
Uh-huh.
disease in the
Right.
population.
Right. Interesting. It's funny, side note, but my great-grandfather died of a goiter because I think it was like before an era where they knew how to treat it or could successfully treat it.
He had airway
I
compromise.
guess so. Yeah. Yeah.
Yeah, yeah.
Which I guess today nobody would die of a goiter.
Yeah, I know. I mean, there's no need to remove these thyroid nodules once they've been biopsy proven to be benign. But
Yeah.
sometimes, if they're well over 4 centimeters, some surgeons will take them out
Yeah.
because of either mass effect
Yeah.
or because of concern that it may have been undersampled with a needle biopsy.
Right. Is it tricky to remove them? I mean, because of where they are?
Well,
Or?
it is a little tricky for a surgeon to do that
Mm-hmm.
because there are nerves in that area,
Yeah.
specifically the recurrent laryngeal nerve, and
Mhm.
so you could develop hoarseness or changing your voice if they injure that nerve.
Yeah.
But in general, it's a pretty routine operation. The good news again with our genetic testing of these thyroid nodules is
Yeah.
that if it's an indolent thyroid cancer, someone can have just a partial removal of the thyroid gland and
Mhm.
thereby not having to
Right.
go on synthroid medication for the rest of their
Right.
life.
I mean, genetic testing, that's another, speaking of advances in treatment of breast, especially, right?
Sure, yeah,
That's a
yeah,
big.
yeah. I mean, for prognostic value as well as for therapeutic
Mm-hmm.
things, we always look at the genetic
Yeah.
makeup of these breast cancers,
Yeah.
look at their receptor studies, and
Yeah. And who would you advise women to look into genetic counseling or high risk assessment
well,
or?
we actually do a risk assessment on all of our patients. We
Mhm.
call it the Thyrocusic lifetime risk assessment.
Yeah.
Now, it's a little bit of work for the patient to do that. They have to fill out a fairly tedious form
Right.
uh, identifying all their family history, breast cancer, age of menarche, age of menopause, various questions. But if they go ahead and fill out that form, we can generate this Thyrocusic lifetime risk assessment.
Yeah.
And if it's more than 20%,
Hmm.
the American College of Radiology would advocate them, considering having adjunctive screening, specifically with breast MRI.
Yeah.
But in terms of, even if they don't fill out the entire form and we don't get that Thyrocusic lifetime risk assessment, we still get enough information that we could identify, for instance, if they say they have more than one first degree family
Hmm.
relative with a history of breast cancer, we'll identify that and we'll suggest that
Yeah.
further a more formal risk assessment should be performed.
Do you offer that at Pure?
Yeah, we offer it in our entire practice.
Yeah.
Yeah.
Yeah. I mean, I would think, for that population also that it could be life changing. I mean, having a mammogram, having
Yeah.
risk assessment, that's really fantastic.
Yeah.
Well, thank you so much for sharing all
You're
this
welcome.
with me. I really enjoyed talking to you and meeting
Thank
you.
you. I appreciated the opportunity to speak with you.